All right, we left off last time on the optic nerve. We talked about visual acuity, and a part of the visual examination that you will perform on every single patient when you do a neurologic examination involves visual field testing. Now, you may have learned, or some will teach, about wiggling fingers out in the periphery, but really our preferred method for testing visual fields involves the confrontation method. So what you do, just as you see here in the optometry office, is the patient covers one eye, you cover the corresponding eye, and then you ask the patient to look at your nose. And then what you will do is you'll just move your hand towards the patient, not too far out, and keep your palm to the patient, and you'll hold up 1, 2, or 5 fingers. It can be a little difficult to tell the difference between 3 and 4, so we usually check 1, 2, and 5. That's a small point. And you will check in all 4 quadrants in each eye. So in this patient, we'll check up here, 2 fingers. We'll hold fingers down here, and then we'll move into the nasal visual field and check over here and down here, and then we'll move to the other eye. So it's very fast. Now, patients often want to look away from your nose at the fingers. So frequently you'll need to remind the patient, stay looking at my nose. Okay, so in this patient, we're testing the right eye. Okay, so let's imagine we're looking on top. Here is the right eye. Okay, the examiner's fingers are out in the temporal outer visual field. Okay, so in the right eye, when she is holding her fingers out here in the upper and lower quadrant, okay, that is striking the nasal retina here in the right eye. Okay, when she moves her fingers over here into the nasal visual field, okay, that is vision that is now coming from this direction, and notice that will strike the temporal retina. So this can be a bit confusing, but you need to keep straight here when we check one eye that we check the temporal visual fields that strikes the nasal retina and the nasal visual fields which strike the temporal retina. Because notice there's a difference in how this vision, ultimately it's going back to the occipital lobe, okay, but notice that information from the temporal retina, which remember sees the nasal visual field, that vision does not cross. Okay, it travels through the optic nerve, optic chiasm, optic tract. Remember, anything that is going to the brain has to synapse through a nucleus of the thalamus. So for vision, it's the lateral geniculate nucleus. And then via the optic radiations back to the occipital cortex. So the temporal retina, which sees the nasal visual field, that vision does not cross. Okay? Whereas the nasal retinal fibers, which see the outer or the temporal visual fields, that vision crosses here at the optic chiasm, entirely crosses. Okay, and goes into the opposite optic tract, lateral geniculate, optic radiations, and occipital lobe. So if you understand that, you can figure out all of the different visual field deficits that patients will have, whether they have a lesion here in 1, 2, 3, 4, 5, 6, or 7. Right, so here are the optic nerves. Here is the optic chiasm. And if we make some sections through the brain, we can see the Napoleon's hat right here. This is the lateral geniculate nucleus for vision that has that distinctive appearance. And we see a pathway synapsing on that. So this is the optic tract. And then from the lateral geniculate, we have the optic radiations, which are traveling back to the occipital lobe. All right, so the optic chiasm doesn't show up the best right here, but this is the optic chiasm, and it will be important that we make a relationship here between the optic chiasm and the pituitary, which is just below, because often a pituitary tumor will compress here on the optic chiasm. All right, so using that information, we need to figure out what kind of visual problems will patients have, let's say, with an optic nerve lesion? Well, here it's pretty obvious. If someone has like optic neuritis from multiple sclerosis, in this eye, let's say this is the right eye, they don't see anything in the nasal visual field, and they don't see anything in the temporal retinal field. So in other words, they're blind. And when there's just blindness in one eye, we call that a monocular visual field loss, monocular visual loss. It's just in one eye. Now, the one here I think that probably boards like to ask more than any other, not that it's the most common, in fact it's really uncommon, but it's just a good way to test your understanding of this, is if we have a pituitary tumor that has grown up and has compressed the center of the optic chiasm, and that's usually what it does. And notice that is going to affect the crossing visual information here that crosses. Well, what crosses? In both eyes, what crosses is the nasal retina here and the nasal retina here. So then you just have to ask yourself, what does the nasal retina see? The nasal retina here in both eyes sees the outer or the temporal visual field. Here in the right eye and in the left eye, vision as it's coming in from the outside strikes the nasal retina. So that leads to a very distinctive visual field loss, which I'll show in just a minute. So let's start with the first one here. Optic nerve lesion, like optic neuritis. Now we're kind of looking at the undersurface of the brain, so this is the left eye, and so we're going to have visual loss just in the left eye, monocular visual loss. Okay, so if we have blindness in one eye, let's just kind of make the point here, the lesion has to be anterior to the optic chiasm. So a blind eye, the lesion is either optic nerve or it's something in the eyeball itself. The patient had a hemorrhage or something. Okay, but the problem has to be here. It can't be anything at the chiasm or behind. Okay, so if we now have that lesion here in the chiasm, that like a pituitary tumor, okay, remember that affects the crossing nasal retinal fibers which see the outer visual field, so we call that a temporal, or it's really a bitemporal, both sides, hemianopia. Hemianopia is just a visual loss, hemi is half. Okay, so a bitemporal hemianopia. So if you see a visual pattern like this, where the outer temporal visual fields are lost in both eyes, the lesion has to be right here at the optic chiasm. Okay, so we'd get an MRI and we'd expect to find something compressing the optic chiasm. Now notice if we have any lesion posterior to the optic chiasm, all of that contains information that is either from the ipsilateral temporal retina or the contralateral nasal retina. Okay, and what does that see? Well, if this is the left eye, let's just say, the temporal retina sees the nasal visual field. The nasal retina here sees the temporal visual field in this eye. And so a visual loss here in blue will affect all vision that is to the opposite side. So if we have a lesion on the left, all of the visual loss is going to be in the right visual field in both eyes. Okay, so here we have a lesion of the optic tract. Now, in a slide I showed you at the end of the last lecture, if you look at that in the optic tract, I may have another picture of it, no, I guess not. The visual fibers are in rotation in the optic tract. And the practical importance of that is when you have an optic tract lesion, because the visual pathways are not in their final fixed location, then usually we have what's called an incongruous homonymous hemianopia, meaning the visual loss is not identical from side to side. So this is kind of classic here for an optic tract lesion. Optic tract lesions, I would say, are really uncommon. Don't see those very often. Okay, so vision goes through the lateral geniculate nucleus here, and then they go through the optic radiations. So It turns out that the optic radiations, a smaller portion of it goes through the temporal lobe, a larger portion goes through the parietal lobe. The temporal lobe part of the optic radiations we call Meyer's loop, okay? And because it's a smaller portion of it, you get just this kind of pie in the sky. So it's a homonymous superior quadrantinopia. It's a little quadrant. It's actually a little bit less than a quadrant. Now here it says incongruent, but these are congruent in this case. They're identical from side to side, but it can be a little incongruent. Okay, so if you find this on examination, you know exactly where the lesion is. You're going to get an MRI scan and you're going to find something in the temporal lobe. Whereas the optic radiations that travel through the parietal lobe, there are much more of them, so it's kind of the opposite, everything that's left. So now we have an inferior visual field loss, and it's more than a quadrant. Okay, and so in a lesion here, you'd be looking for a parietal lobe lesion. Remember, always contralateral. So one other point I probably should have made, here the lesion is on the left, and so what you want to imagine is the patient is looking at the screen. So this is the right eye, this is the left eye. This is what the patient sees, and actually the black area is what they don't see. Now, what we see most often is a middle cerebral artery stroke that involves all of the optic radiations. Okay? And so if you knock them all out, then you're going to have a complete visual field loss in the contralateral visual field in both eyes. Okay, so if we say here our lesion is on the left in blue, then the patient is not going to see any of the blue here on the right side in either eye, from the nasal retina in the right eye and from the temporal retina in the left eye. So all vision to the opposite side will be lost. And so sometimes these will present. In fact, a common way to ask a board question about this is a patient driving who keeps running into trash cans on one side because they can't see them. Now, an occipital lobe lesion is very similar. Okay, so now we're looking at the undersurface of the brain, and so here's our lesion back here, and this is usually due to a posterior cerebral artery stroke, because the posterior cerebral artery supplies the visual cortex back here. And so what is very unique about this is that, the lesion here is on the right, so as the patient looks at the screen, they have a left visual field loss in both eyes, but you'll notice there's this area of central sparing of vision. That's called macular sparing. And that is a classic finding in a posterior cerebral artery stroke. And the reason that occurs is that there's a dual blood supply to the macular fibers that are traveling back here. The middle cerebral artery actually supplies the macular fibers as well. So if we have a PCA stroke, we look for this macular sparing. So if you ever see this visual pattern you're shown on an exam or you see it in a patient, it has to be a PCA stroke. Okay, that's the only thing that could do that. Now, the next thing we can do to evaluate the optic nerve, and actually this is the only part of the central nervous you can actually see on the physical examination, is an ophthalmoscopic examination. Okay, and Dr. Schenkel is going to go over this in more detail about, looking at the cup to disc ratio and the retinal arteries and veins and all of that. Okay, now I should disabuse you of the notion. It took me a long time into medical school to figure this out. I always thought I'm going to look in the eye and this is what I'm going to see. Well, it turns out when you look in the eye, you see a little thing about this big, and you have to keep moving the ophthalmoscope around to find what's going on. So we get these beautiful pictures, but in real life, you'll never see something that looks like this. So a couple of things that we look for neurologically. In fact, two of the prime things that we're looking for is just the health here of the optic nerve head. And so let me go back to what a more normal optic nerve head, and notice the nice disc margin right here. So this is normal. Now notice this, we have a very bright appearance of the optic nerve head. This is called optic nerve pallor, and this is something that we would see after a patient has had an optic nerve injury, like optic neuritis. Okay, that what happens over time is you get atrophy, and that has the appearance of just a bright spot there on the optic nerve head. The other thing that we're looking for is papilledema. And we'll have an entire lecture on increased intracranial pressure later on in the course. But when there's some mass effect in the brain, a hemorrhage or a tumor, there's nowhere for that pressure to go. Very few places. I mean, this is why brain herniation is such a risk with increased intracranial pressure. But one of the places that the pressure can travel to is right forward to the optic nerve head. And so notice the disc margins here are very blurred. This seems to be just kind of pushing out, and this is called papilledema. And so when someone comes into the emergency room for headaches, it's very important you look in the eyes, because if you see papilledema, you know, okay, this is a neurologic emergency. We need an urgent brain scan. We need to figure out why this patient has increased intracranial pressure. I will say that of all the different parts of the neurologic examination, the ophthalmoscopic examination is the most difficult. There was a recent study looking at physicians and their skills at the ophthalmoscopic examination, and they were universally very poor. And so I would just encourage you throughout medical school, every time you get a chance to look in a patient's eye with an ophthalmoscope, do it. Because to get good at this, and I can just say from practical experience, I remember I was an intern at the Riverside County Hospital, and I had a patient coming in with headaches, and I looking in the eye, and in that moment I realized, you know what, I'm not really good at all at this skill. It's something that I never really learned very well. So it is something that with practice can be quite rewarding, and when you can look in, you can diagnose papilledema, you know, you'll be on the right track for evaluating that patient. Okay, and so here we see very prominent optic nerve pallor. I mean, look at the brightness there. And so again, when you look in the eye, you don't see this, okay? Your window of what you see is like this. So this is why when we teach this in the clerkship, how to do the ophthalmoscopic examination, you need to be moving around a lot. You know, you need to follow a retinal artery or vein, follow it back to the optic disc. You know, you need to be really kind of jockeying around while you look in the patient's eye if you're going to appreciate, you know, a good extent of the optic nerve head and the optic and the retina. All right, now let's talk about cranial nerves 3, 6, and 4. And these are the ones that are involved in eye movements. Okay, and the third nerve is also involved in pupillary constriction. So first we'll talk about the pupillary light reflex, which is actually a reflex that involves cranial nerves 2 and 3. Okay, and so the size of the pupil is dependent on a balance between the sympathetic and parasympathetic innervation of the pupil. And so let's explain first what normally happens here. Let's say you shine the light in the eye. And so this is one of the first things, like a patient rolls into the emergency room, unresponsive. One of the first things the emergency room doctor will perform is shine a light in the eye, because you quickly, without the patient needing to be awake, get information about 2 cranial nerves, and you get information about the midbrain, which is kind of where most of this information goes in and out. And actually you get a lot of other information in the coma lecture, which I will talk about. So let's explain the anatomy of what happens. So we shine the light in this eye. Okay, let's say we're looking down on top of the eye. This is the left eye. So that light then travels down through the optic nerve. Okay, some of the light will cross over at the chiasm, some will stay on the same side. Okay, and then it travels through the optic tract on both sides. It goes through a nucleus back here in the dorsum of the midbrain called the pretectal nucleus. And there's actually another crossing here in the posterior commissure. Okay, so there's really a double crossing of light here at the optic chiasm, here in the posterior commissure. And so the light in one eye, because of the double crossing, will equally stimulate both Edinger-Westphal nuclei. And the Edinger-Westphal nuclei, this is an important nucleus to remember by name. This is a parasympathetic nucleus that contributes parasympathetic nerve fibers to the oculomotor nerve, the third nerve. So these travel right along with the third nerve, and the parasympathetic fibers have a synapse here at the ciliary ganglion, where they then travel out to the pupil to constrict the pupil. Okay, so the parasympathetics constrict the pupil. And this is the mechanism of shining a light in the eye that will notice shining light in one eye will equally stimulate constriction of both pupils. Okay, so when you shine the light in one eye, you want to see what is happening to both pupils when you do that. So here's the midbrain. And remember, right above the midbrain right here, we have the posterior commissure. Okay, so the crossing of light will cross both in the optic chiasm here and in the posterior commissure right here. Okay, here is another representation. So now the midbrain is kind of flipped around. Hopefully it's not too confusing. But here we have light here, and I think unfortunately this drawing doesn't show the other. I think they wanted to make it not too confusing. But here you can see light going into the pretectal nuclei, stimulating the Edinger-Westphal nuclei, and just one half is showing out through the ciliary ganglion to constrict the pupil. But the reason I wanted to show this drawing is that the pupils also constrict when you look to your nose. And that is called accommodation. And so when we're checking eye movements in a patient, we will also take, as the examiner, you'll have the patient track your finger, and then you will have them follow your finger to the patient's nose. So the eyes have to look towards the nose. And so if you're tracking someone's finger, well, you need to see that, right? So you see it with the occipital lobe, okay, which in a, I would say, poorly understood manner, actually activates the pretectal nucleus, but by a different location. It's not entirely clear, but that then activates the Edinger-Westphal nucleus to constrict the pupil. So there's pupillary constriction not only to light stimulation, but also to accommodation. And so what I would try to remember here, and again, the neuroanatomy is not entirely clear, but the pupillary constriction that comes from light is anatomically somewhat different in its involvement of the pretectal area or nucleus than the activation from accommodation here from the occipital lobe. Okay, and this is why later on when we talk about lesions that can occur back here, like neurosyphilis is kind of a classic one, what we'll often see is that the pupils will not constrict to light stimulation with the lesion here, but yet they are able to constrict to accommodation. Okay, and so usually when we see that discrepancy, the lesion is kind of in the dorsal midbrain area right here. Okay, so that is parasympathetic for constriction of the pupil. Now the sympathetics dilate the pupil. And this is a favorite board question for years. I've always said like top 5 question for neurology boards involves the pupil, and frequently they want you to know what happens with a lesion of the sympathetic pathway. And I think that's because this is such a long circuitous route here to dilate the pupil. It's a 3-order neuron chain. So the hypothalamus is the head ganglion for the autonomic nervous system. So this is where it begins, okay? And these fibers travel importantly through the lateral medulla. Later on we talk about lateral medullary syndrome. I'll remind you that the pupil is involved with the lesion there. And the first synapse occurs in the lower cervical upper thoracic cord from about C8 to T2, okay? So if you want to impress neurologists, you can say it's the ciliospinal center of Budge. I don't care that you know the name, but I'd like you to know the location in the spinal cord, or the level of the spinal cord. Okay, the second order neuron travels from there. It exits with C8 and T1 nerve roots, travels along with the plexus a little bit, and then loops around the apex of the lung, kind of travels around the subclavian artery, and then the next synapse here involves the superior cervical ganglion. From there, some of the fibers take off with the external carotid artery to supply blood vessels and sweat glands on the face. Okay, but for the pupil, it travels up with the internal carotid artery, and I don't expect you to understand all of this. I don't think it's that important, but what I would like you to know is that the fibers, sympathetic fibers that travel along with the internal carotid artery, these are the ones that through a very complex pathway end up supplying the pupil dilator muscle and also a muscle that is a minor eyelid elevator called Mueller's muscle. Okay, so those are the two things that are supplied by this third order pathway that goes along with the internal carotid artery. So this whole pathway then, what does it normally do? It normally dilates the pupil. Okay, so when the room lights darken, your pupils enlarge. Why do they enlarge? Because this pathway is immediately activated to dilate your pupil. And this pathway also elevates the eyelid somewhat. Okay, now this is not the major eyelid elevator, it's a minor eyelid elevator, but it still has an effect to elevate the eyelid. And it supplies blood vessels and sweat glands on the face. So what will happen with a lesion, whether it is of the first order, let's say in the lateral medulla, or of the second order, let's say the patient has an apical lung tumor, or a third order, the patient has some lesion of the internal carotid artery, you lose the stimulation to dilate the pupil, so the pupil becomes smaller. That's called miosis. You also lose a little bit of eyelid elevation, so you get a droopy eyelid, and that is called ptosis. You don't pronounce the P, just ptosis. Okay, so looking at a patient here, we'll notice that the right pupil is smaller. It's usually even more subtle than this, and there is some ptosis. So this is what's known as a Horner's syndrome. Now, when you see someone like this, it turns out that 18% of the population have asymmetrical pupils. That's called benign anisocoria. 18%. So you will see lots of people. I mean, if we were to go through every medical student in the class, we'd find, about 1 in 4, 1 in 5 that would have asymmetrical pupils. So if you want to convince yourself, is this significant or not? This looks significant because you've got the ptosis. But what you should do is dim the room lights. Because dimming the room lights, remember, that is going to cause the pupil here to dilate, the normal pupil. Okay, that's from sympathetic activation. But over here, since we have a sympathetic lesion, this pupil can't dilate. Now you have a very dramatic pupillary asymmetry. So dimming the room lights helps to confirm, okay, this is real, this is significant. If someone just has benign anisocoria and you dim the room lights, both pupils are going to dilate to the same degree. They'll still be a little bit asymmetrical. When they become very asymmetrical like this, you know you're dealing with a bona fide Horner syndrome. Okay, so the most common, if we're just going for boards, they always ask you about an apical lung tumor. That's a common board question. Or a lateral medullary syndrome. Okay, so those two would be really important to remember. We can also have trauma of the internal carotid artery, like a dissection. I saw a patient years ago who was in a car accident, and the seatbelt rubbed against the carotid artery, and it caused blood to dissect into the wall of the carotid artery, which caused it to swell out. It compressed the sympathetic pathway here, and he came into the emergency room with, among other things, a Horner's syndrome. Now, one localizing factor here is if the lesion is either a first order or a second order, then you will look for a lack of sweating on the ipsilateral face. That's usually around the forehead area, around the eye. That's called anhidrosis. Okay? If the lesion is of the internal carotid artery, then you're only going to have the miosis and the ptosis. Okay, so just practically, it can be difficult to determine if there's a loss of sweating. Okay, but at least if we're talking about a board question, that could be something that may be helpful. So again, for Horner syndrome, you have meiosis, ptosis, and if it's a first or a second order Horner syndrome, you get anhidrosis. Okay, so another patient with meiosis and ptosis. Okay, so first order lesions, I mentioned a brainstem stroke, especially in the lateral medulla, or any hemorrhage in the brainstem. Since these fibers travel through the cervical spinal cord, if someone has a high cervical cord lesion, or like a demyelinating condition like multiple sclerosis of the cervical cord, you could get a Horner syndrome. I highlight this just because of its frequency on board questions. A Pancoast or an apical lung tumor will give you a Horner syndrome. And then a third order lesion like a carotid artery dissection, the example I gave, or there are certain headache syndromes where someone during a migraine or during a cluster headache, you might get a little swelling of the carotid artery. It's probably more complex than that, but the patient can have a Horner syndrome, if they look in the mirror when they're in the midst of their headache. Now when we check eye movements, I'll usually use a pen or something like that, and we'll have the patient follow the pen in an H pattern. And that allows us to check all of the extraocular muscles that are supplied by cranial nerves 3, 4, and 6. So here's a nice medical student drawing here from a couple of years ago showing that we have the oculomotor nucleus. The third nerve supplies the majority of the eye muscles. The other two just supply one. So the abducens nucleus travels out here to supply the lateral rectus. The trochlear nucleus, remember this is the only cranial nerve to exit from the dorsum of the brainstem, has a very long path that travels all the way to the superior oblique. Right, so again, if you just want to remember, 4 supplies superior oblique, 6 gets the lateral rectus, all of the other eye muscles are supplied by the third cranial nerve. So SO4, LR6, everything else is 3, is a way to remember that. Okay, so when we ask a patient to follow in an H pattern, looking up and over this way and looking up, we are assessing all of these extraocular muscles. And so with some of these, it's really easy, like the lateral movements. The lateral rectus moves the eye out, or abducts the eye. The medial rectus moves the eye towards the nose. Okay, these other muscles here are much more complex to understand. So it isn't just as straightforward as saying, oh, the superior rectus moves the eye up and out. And the reason it's more complex than that is there's tension between these extraocular muscles as the eye is in different positions. So a better way of saying it would be this. When the eye is in the abducted position, the superior rectus then has its strongest action to elevate the eye in the abducted position. When the eye is in the abducted position, the inferior rectus has its strongest action to pull the eye down. Okay, when the eye is in the adducted position, the inferior oblique has its strongest action to pull the eye up. And when the eye is in the adducted position, the superior oblique has its strongest action to pull the eye down and towards the nose. Okay, that's the big picture. So because this is confusing, I hope this helps. I had a medical student years ago draw this out. And so for the superior muscles, you need to pretend like we're looking on top of the eyeball. Okay? And the star indicates the action, the strongest action of each of these muscles. So notice now we're looking on top of the right eyeball in all of these cases, so that when the eye is abducted, notice now that the muscle here, the superior rectus, is stretched, so it has its strongest pulling action. So that's why the superior rectus is strongest when the eye is in the abducted position. Okay, as far as the superior oblique, when the eye is towards the nose, okay, then imagine that just stretches all of this. And so the action then of the superior oblique is strongest when the eye is towards the nose, and then it is purely going to depress the eye. It's going to move it down towards the nose. As the eye moves out, here now we're looking on the undersurface of the, the upper surface of the right eye. But as the eye moves into the abducted position, now just imagine the pulley action here, then the function of the superior oblique when the eye is abducted is almost entirely in cyclotorsion. And I'm sorry I should have the video on to show you this, but it is like this action, down and towards the nose, but it's a torsional eye movement. If we look on the undersurface of the right eye here to find out what the inferior rectus does, when the eye is in the abducted position, the inferior rectus is stretched and therefore very strong to depress the eye. Okay, and for the inferior oblique, when the eye is in the adducted position, it has its strongest action to elevate the eye. So let's give some examples then of what can happen with lesions of these different cranial nerves. So in a third nerve palsy, so remember all of the extraocular muscles are affected except for SO4-LR6. So here we have a patient with a right third nerve palsy. Okay, and so remember the medial rectus is supplied by the third nerve. So you lose all pull towards the eye. The lateral rectus is sixth nerve. So it's normal, it's unopposed. So in a third nerve palsy, the eye gets pulled out, okay? And a little bit from the superior oblique, you get a little bit of a down movement as well. So with third nerve palsy, we say the eye is down and out. And notice that there is some droopiness of the eyelid here. Okay, because the major eyelid elevator is supplied by the third nerve. So you also have a very significant, in fact, frequently, the ptosis is complete in a third nerve palsy. And you have to, as an examiner, lift up the eyelid just to be able to see the eye at all. But I wanted to draw this so you could, see what the eye looks like. The other thing that you will notice in a third nerve palsy is look at the pupil size. So here's normal, this pupil is dilated. Because the third nerve supplies, as we said before, the parasympathetic fibers travel with the third nerve to constrict the pupil. So you get mydriasis. Okay, so in a third nerve palsy, again, the eye is in the down and out position. You have ptosis, you have mydriasis. Now, remember that I said when the eye is in the abducted position, what's the function of the superior oblique? It's in cyclotorsion, which looks like this. So if we were to ask this patient, and I didn't know how to communicate this here in a drawing, but now look to the left, well, they can't move the eye to the left, but they would have some encyclotorsion movement. So this is how we would be able to say this is an isolated third nerve palsy, the fourth nerve is working. Okay, at the end of the course, you will know 5 causes of a third nerve palsy. They're all very distinct and have different clinical presentations. And here they are. So these are the 2 we've talked about so far. So remember uncal herniation, the uncus is near the third nerve. So here the patient will be unresponsive in a coma and they'll have a third nerve palsy. And the posterior communicating artery, recall, is close to the third nerve. So if we have an aneurysm that ruptures here, the patient will have a severe headache and a third nerve palsy. Okay, and these are the 3 other causes that we will talk about later in the course. But for planned redundancy, if you want to remember these now, and we'll explain what they look like later and how we can contrast them with these 2 causes. All right, now in a 6th nerve palsy, this one's really easy because you're just losing one muscle. So just as the patient here is in primary gaze looking at you, it's kind of subtle, but the medial rectus now is relatively stronger than the lateral rectus, so the eye tends to get pulled in a little bit. Okay, and so now when we ask the patient here to look to the right, this eye moves over fine, but we lose the abduction in this eye. Okay, notice though that when we ask the patient to look to the left, there's no problem with the medial rectus, that's third nerve. So the eyes are more conjugate, which means they're more lined up when the patient looks to the opposite side. So in a 6-nerve palsy, none of the cranial nerves cross except for 4, and that is not clinically significant. And so always with any cranial neuropathy, the weakness is on the same side. So in a right 6-nerve palsy, the patient will have weakness with abduction on the right side, and therefore double vision when they look to the right. Now, if you see a patient with a bilateral 6-nerve palsy, so notice now, you might appreciate much when the patient's looking straight ahead, but when they look to the right eye does not abduct, and the eyes are disconjugate. When they look to the left, now the left eye does not abduct, and again the eyes are disconjugate. So a bilateral 6-nerve palsy, there's a differential for this, but for now, this is often something that we'll see with increased intracranial pressure. That pressure in the brain as it pushes down damages the 6th nerve on both sides. So, if you're seeing a patient in the emergency room with headaches and they have a bilateral 6th nerve palsy, it's a neurologic emergency. They have increased intracranial pressure. You need to get an urgent CT scan, figure out what's going on. Now, 4th nerve palsy, these are often difficult to diagnose. And what you will find in a 4th nerve palsy is that the patient wants to tilt their head in the opposite direction, and that allows the eyes to line up a little bit better. So this child here has a left 4th nerve palsy. And what you can appreciate always, remember the function of the 4th nerve is to pull the eye down towards the nose. And then when the eye is in the abducted position, it has some encyclotorsion down towards the nose. And so here you can just appreciate you lose a little bit of that down pull, and this is very subtle, but there's a little bit of hyperopia. This left eye is a little bit higher. Okay, so this child is always going to prefer to tilt their head in the opposite direction because that lines up the eyes a little bit. Notice when we ask the child to look to the right, still the left eye is a little higher. Again, you're losing the down pull of the superior oblique. And so this is what's often most helpful, and I'll show you another one that's more obvious. Ask the patient to tilt their head towards the same side, and now you notice the eyes are really disconjugate. This eye is much higher. And so to prove this to yourself, I would pause the video, find a mirror, and fixate on the mirror and tilt your head to the left. And notice what your eyes are doing when you tilt your head to the left. What happens is this eye needs to excyclotort, this eye needs to encyclotort, that's superior oblique function. And so for this child, when she tilts her head to the left, she's lost the encyclotorsion from the 4th nerve, and the eye goes up. And so she's going to have double vision whenever she tilts her head towards the side of the lesion. So that's why patients want to always tilt their head in the opposite direction. Okay? 4th nerve palsy can occur due to head trauma. It's a very long, thin nerve, so it easily gets damaged in head trauma. And often patients, they compensate pretty well by just tilting their head. And so if you want to find out when the problem began, I'll have a patient just go through their phone and show me pictures. And what you'll find is in every picture, they're slightly tilting their head to one side, and you go back to a point when suddenly they're not tilting their head to one side, and then you can kind of hypothesize, well, that's when the problem began. Okay, and there's a lot of confusion because a lot of anatomy textbooks and review books will talk about a down and out function of the superior oblique. And I had a little wording in the handout about why I think some of that verbiage gets in. So I just want to convince you of this. Here is the Bible of Neuro-Ophthalmology. They have a more recent edition. but if I want to go to something authoritative about the eyes, so just notice in primary gaze, in other words, when the patient is looking straight ahead, the action of the superior oblique is down and towards the nose, and there's some encyclotorsion down and towards the nose. When the eye is in the abducted position, the superior oblique acts to encyclotort, and when the eye is looking towards the nose, remember that's the strongest action, it's a pure depressor. So here the Walsh and Hoyt, they even say depression is essentially nil when the eye is in the abducted position. Okay, and here you can just read some other, here's the textbook for the course, Kendall and Schwartz, just kind of talking about the action of the superior oblique. So there really shouldn't be confusion about this eye muscle. Here's just one other example of a 38-year-old woman after a car accident, motor vehicle accident. And so notice this is subtle, but in all positions, there's just a little hyperopia. This left eye is a little bit elevated. Okay, and it's just from losing that, depression action here from the superior oblique. When we ask her to look to the right, we lose that pull, that depression, so this eye actually goes up just a little bit. Ask her to look to the left, the eye is still just a little bit higher. Ask her to look up, the eye is a little bit higher. Ask her to look down, the eye is still a little bit higher. And now to really convince ourselves, we need to ask her to tilt her head to either shoulder. So again, you want to tilt your head to the opposite shoulder, and now notice that they're conjugate, right? Because when you tilt your head to the right, this eye encyclotorts, this eye excyclotorts. Okay, this is not a function of the superior oblique, so the eyes are conjugate. And now when we ask her to tilt her head to the left side, this one's more obvious than the other one I showed you, she has complete inability to encyclotort, and so she's going to really have double vision than if she were ever to tilt her head to the left shoulder. Okay, so we'll go through brainstem sections later, but if you see a cranial nerve exiting from the dorsum of the brainstem, it's the fourth nerve. Okay, and from our brain dissection lab, I tried to color this. Remember, if you pull the temporal lobe away, you can see the cerebral peduncle here. And so here's the third nerve. Can't really see the third nerve over here, but the fourth nerve wraps around the cerebral peduncle. A really small, fragile nerve, because there aren't that many nerve fibers needed, right? It's just going to one muscle. Now let's finish off today just talking a little bit about three types of conjugate eye movements. Conjugate means the eyes are tracking together. They're aligned together in their action. Okay, so there are two that fixate the image on the retina. All right, so one is called the vestibulocular reflex, and the other is called visual pursuit. As a big picture, the vestibulocular reflex is something that we utilize every second of the day. Anytime you bounce around, move your head, even if you're sitting, the eyes are constantly moving in the opposite direction so that we can maintain alignment and fixation. Okay, if we didn't have a really good vestibulocular reflex, if you've seen any of those old cops TV shows, there's some poor cameraman running into the house behind the police officer and everything is bouncing up and down. That's what things would look like if we didn't have a vestibulocular reflex. Okay, pursuit is fairly obvious. You're tracking something in space. And then we'll spend quite a bit of time talking about this one, a visual saccade, which is an ocular movement that redirects the line of sight. So if we just imagine you're sitting in a train and you're tracking something as the train travels by, that would be a visual pursuit. Okay, but then you catch up to look at the next object that's ahead of the train, and that quick eye movement to catch up and look at something else is called a visual saccade. All right, so this anatomy here is a little bit difficult. I'll just tell you that there is a payoff to understand this because these are things that we check routinely on examination in patients. So vestibulocular reflex, in a nutshell, fixates the image on the retina with respect to head movement. And so if you'll just notice, again, you can look in the mirror, if you quickly turn your head to the left what do the eyes do? They precisely move to the right. Okay, how does that happen? Well, here we're looking on top of the eyes. So here's the left eye, the right eye, here's the nose, here's the left ear. Okay, and so we move our head to the left. Okay, what happens? Well, when you move your head to the left, it actually stimulates flow of endolymph in the semicircular canals in your inner ear. Okay, this happens in both ears. And so that information is converted to an electrical signal which synapses in the vestibular nuclei. Okay, and in the subsequent slide, I'm going to explain all of this in more detail. Now I'll just kind of give the big picture that from the vestibular nuclei, notice that we end up here activating the opposite sixth nerve nucleus. And what does the sixth nerve do? It supplies the lateral rectus. So moving the head to the left ends up activating the right lateral rectus, which then moves the right eye to the right. Now we need the left eye to cooperate and also move to the right. So also from this nuclear complex here, it's not just the sixth nerve, we call it the PPRF sixth nerve complex. This crosses over and talks to the part of the third nerve nucleus that talks to the medial rectus. Okay, so moving your head to the left should immediately cause the eyes to move to the right. And this is the vestibulocular reflex. So we can check this on examination by doing what's called the doll's eyes or the oculocephalic reflex, where we will quickly move the patient's head, in this case to the right, and we just ask the patient to maintain fixation. Keep looking at me while I do that. And notice that she's able to, her eyes both quickly go to the left. So this would be a normal oculocephalic or doll's eyes reflex. We utilize this in patients who are unresponsive or in a coma. And you want to make sure they don't have any neck pathology, you know, when you're moving the neck around. But you just lift up the eyelids and you quickly move the eyes to the right. And if the oculocephalic reflex is intact, the eyes will precisely move to the left. This is valuable information. You know, you've got a patient in a coma, you're evaluating in the emergency room, and if they have an intact oculocephalic or doll's eyes reflex, that tells you that all of this neuroanatomy here traveling through the pons and through the midbrain is all working. So whatever reason for the unresponsiveness in the coma, you just ruled out a large portion of the brainstem. You could just say that that whole area of the brainstem, including cranial nerves 3 and 6, they're all working. So that's very quick, valuable information. Now, another very potent way that we can activate the vestibulocular reflex is called cold caloric testing, where we irrigate one ear with cold water. And later on, I will explain how that works. Now, a visual saccade. Recall this is a quick eye movement. You know, you're tracking something in a train and then you catch up with the next object. That's a visual saccade. And we are going to come back to this drawing many times in the course. So just be warned ahead of time. You need to know this. You need to be able to draw it out on a blank sheet of paper. You will get many questions right throughout the course just by understanding this pathway. Okay, so the big picture here is that the left brain, and notice where are we pointing here? This is the middle frontal gyrus, and so these are the frontal eye fields or the saccadic gaze center that we learned about earlier. So this area of the left brain normally wants to drive the eyes to the right. Okay, and it does that through this pathway that activates the opposite PPRF sixth nerve complex in the pons on the opposite side. Okay, the sixth nerve talks to the lateral rectus to move the right eye, to abduct the right eye. And the PPRF, which is the paramedian pontine reticular formation, think of this as the horizontal gaze center of the brain. It's meant to coordinate our eyes when we're moving from side to side. Okay? And from the PPRF, this pathway, very important pathway called the medial longitudinal fasciculus, activates the part of the third nerve that talks to the medial rectus. Okay, so when you quickly move your eyes to the right, this is what's happening. This part of the left hemisphere, frontal eye fields, is activating the right pons to move the right eye to the right, and then via the MLF and the third nerve, the left eye moves to the right. Normally, the right and left hemisphere, they're perfectly coordinated. There's equal tension on both sides. So when you want to move your eyes to the right, this becomes relatively more active, and the right hemisphere frontal eye fields become relatively less active, and the eyes go to the right. Now, because this will help us to localize lesions later, I want to show you here the corticospinal tract, okay, which, remember, crosses down here in the medullary pyramid to move the opposite side of the body. And I put this in, well, it'll be obvious here as we talk about lesions here over the next few slides. Okay, so just with that, let's say we have a patient now that has a left middle cerebral artery stroke. Okay, well, what side of the body is going to be weak? That's fairly obvious. The opposite side of the body is going to be weak. Okay, so with a left hemisphere lesion, the patient will have weakness of the opposite right arm and leg. But now, which way will the eyes look? Even if you didn't remember anything about this, if you know that the left frontal eye fields want to move the eyes to the right, well, if you destroy this, they can't look to the right, and they get driven to the left by the right hemisphere of the brain. So again, you're losing all of that stimulation of the opposite PPRF6, which wants to move the right eye to the right, and you're losing all that stimulation to the left eye medial rectus, which wants to move the eye to the right. So with a left middle cerebral artery stroke, the eyes get driven to the left, and the patient has right-sided weakness. So most review books say the eyes look at the lesion, but I like to say the eyes look away from the hemiplegia. Okay, the eyes are looking to the left, the right side of the body is weak. The reason I think this is a more helpful way to remember it is that when you walk into the emergency room and you see someone whose eyes are looking away from the weak arm and leg, you don't know where the lesion is yet. All right? But if you have this finding, you can say, okay, eyes are looking away from the hemiplegia, so this has to be a contralateral, probably middle cerebral artery stroke. Okay, so that's the first one. Second application, and I'm putting the lesion now in the right pons, and I'm doing that just because this is how the other drawing was, all right? So we're using the same, neuroanatomical drawings. So if we have a lesion in the right pons, okay, first of all, what side of the body will be weak? Well, now here's our corticospinal tract coming from the right hemisphere. So with the right pons lesion, the left side of the body is going to be weak. Okay, now which way will the eyes look? Okay, and to answer that, just ask yourself, what does the right pons normally want to do? Well, the sixth nerve wants to supply the lateral rectus to abduct the right eye. The PPRF wants to stimulate via the MLF and the third nerve nucleus, the medial rectus to look to the right. Okay, so you lose all that stimulation for the eyes to look to the right, so they get driven to the left. Okay, the patient has left-sided weakness, the eyes get driven to the left, so with the lesion in the pons, the eyes look at the hemiplegia. Okay, there are some variations of this, and when we go through our lecture on the pons, I'll remind you of this, and we'll also talk about some other more complicated syndromes that can occur. But just whether the eyes are looking at the hemiplegia or away from the hemiplegia is just quick, valuable information at the bedside. Now, if we have an isolated lesion of the medial longitudinal fasciculus, and this is a classic area that is demyelinated in multiple sclerosis. This is like a pathognomonic finding of multiple sclerosis. What's going to happen? Well, when you think of the medial longitudinal fasciculus, I only want you to think of one thing. This supplies the part of the third nerve that talks to the medial rectus. So when we have an MLF lesion, okay, the medial rectus on the same side is weak. Okay, so when this patient tries to look to the right eye can abduct, no problem, but the left eye can't move towards the nose. It can't adduct. So the patient's going to have double vision when they look to the right. And this is called an internuclear ophthalmoplegia. Ophthalmoplegia is just a big word for an eye movement problem. Internuclear because the lesion is between nuclei. It's between the PPRF6 nerve complex and 3, an INO. And if you see this eye movement problem in a younger patient, you could be very confident that they have multiple sclerosis. So here the lesion is on the left. Now the patient is looking at us. Okay, so just looking straight ahead, you don't notice too much. When the patient looks to the left, no problem. But now, when they try to look to the right, notice that the problem is with the left medial rectus. When they try to look to the right, the left eye can't look towards the nose. Okay, the right eye, the brain doesn't like double vision. So the brain tries to bring the right eye, keeps trying to bring it back. So we get some nystagmus in the normal eye. And oftentimes you can look at that and say, wow, look at that eye shaking back and forth. Well, the real problem is here, that this eye can't move towards the nose, and the brain trying to bring the images together, you'll see some nystagmus in the normal eye. Okay, in class, I will show a number of videos to help illustrate this, and I think that's a good time to stop.